Our next speaker is Dr. Sigurd Berven, who's professor of orthopedic surgery at UCSF. And we're going to zoom out from a very specific topic to looking at his perspective on spine surgery over the last 20 years. What are we doing better, and where do we fall short?
Well, thanks to Lionel and Kyle and Lee for the opportunity to contribute again. I'm wearing a jacket because every time I come in here off the water, I'm freezing cold in here. And it's not so much the formality as much as the temperature. This is a real, both an honor to be able to talk on 20 years of perspective, as well as a bit of a reality. Is I look around and I guess there's only a small number who really could talk about 20 years. So I got 20 minutes to talk about 20 years. We got Bobby and I started together, so Bobby could do it. Let's see, Shane and Praveen, and Praveen's been around for 20 now, yeah. Chris Ames within the UCSF group, of course, Rick Fessler and some others good from outside. But I'm going to share with you some of the things that I think have changed that are better, and importantly, where's there still some room for improvement and disclosures. So, you know, overall, innovations in medicine have really led to some really important improvements in life expectancy, quality of life, and importantly, access to care. In spinal disorders, I often start talks with the fact that what we do as a community of physicians who take care of problems of the spine is important. It's important whether we measure it by the impact of spinal disorders on quality of life, whether we measure it by the prevalence. So the burden of spinal disorders is important in healthcare societies internationally. And this is a big driver of why what we do is important. So there's some really positive innovations, and I'm going to talk a bit about some of the work we've done with surgical planning and modeling. I think some biologics in the last 20 years have made a difference. Navigation, I think, has made a big difference. I'll give you some examples of that. And some areas where we've fallen short. You know, quite honestly, I think healthcare reform's fallen short. I think there's still some really perverse incentives for doing inappropriate things in medicine. I think some of the things we've done with regenerative medicine, I think Rick's going to talk about this, but you know, so far I've been a little disappointed. In the last 20 years, I started working with Jeff Lotz on regeneration of the disc, and we haven't made a lot of advances in that. And you know, again, quite honestly, some of the predictive models, Chris and I share a lot of enthusiasm for developing these models, and they tend to be very impressive within our test-retest reliability, but when we try and apply them more broadly, our areas under the curve are in the range of about 0.6, which is about the same as guessing. And I'll just focus on where I think there's been some important changes across the continuum of care. So I think about a lot of things as preoperative, intraoperative, post-operative, and across that continuum, I think there have been some changes in each of these areas. You know, putting this into perspective, I said what we do as spine physicians, spine surgeons, what we do is important. And just thinking about innovations in medicine, it's a little bit humbling to really recognize what are really important innovations. You know, Carrico and Weissman at Penn, and some of you may know, Catalin Carrico is actually in the Department of Neurosurgery at Penn, and they developed the mRNA vaccines that led to COVID, and they got the Nobel Prize in 2023. I don't have anything in spine surgery that really compares to that. And the work that Allison and Hanjo have done in the University of Texas, as well as Kyoto University, they won the Nobel Prize in 2020 for work with immunotherapies. You know, those are really dramatic things. So I don't think I can identify anything in spine that's really been that dramatic, but I'll show you what I think has been important. When we think about new technologies, I think Thomas Friedman showed us improving access to information. Robin Young talks a lot about large data. I think the promise of new technology is to really look at larger data sets, get more generalizability from our data, to increase our productivity, to reduce errors. You know, medical errors remain a major reason for mortality in large hospitals, to save lives and, of course, to improve quality of life. This is where the promise is. And just looking back again with some introspection on 20 years ago, I showed up as a fellow at UCSF, well, 25 years ago, I showed up as a fellow at UCSF, and I had the newest BlackBerry. This was in 2000. And this BlackBerry had a RAM of about 750 megabytes and a total storage capacity of about 6 gigabytes. And you know, the phone in my pocket right now has got 256 gigabytes of total storage capacity. And so that brings us to Moore's Law, and Gordon Moore recognized at Intel back in the 1960s. He recognized, hey, every 2 years we're improving our computer capacity, we're improving our storage capacity, and indeed that has continued even through today. We continue to improve capacity over time. So I often ask the question of what would happen if we had that level of improvement of technological capacity, if we had that level, if we applied it to medicine. So I would imagine if we had a doubling of capacity, the equivalent in medicine would be, a halving of every year of infant mortality rates or of our implant failure rates, which are so common, readmissions, reoperations, complications. And the analogy with other areas of technology would suggest that we would have been able to do that, and we certainly haven't. And I'll show you evidence to suggest that there are some areas where we've failed. We've certainly not kept up with the increases of capacity that Gordon Moore described. Here's one example is, and when I came out here as a fellow, I drove a car that looked a lot like this. This is a 1993 Saab convertible, and this is my first car in California. And Bobby's going to laugh because my present car is about like this. I thought by this time I'd be driving a flying automobile, but instead I've got a car that's substantially equivalent. Bobby's upgraded his car, but I haven't. And well, what about the positiveness of change? And this is a paper that I think is relevant out of St. Louis, and this was published in 2002. And Keith Bridwell and a group in St. Louis took a look at basically over the past decade in St. Louis, did they really make a lot of improvement with using screws over hooks, essentially, or basically with using, how good was old technology, so segmental hooks and rods, Wisconsin wires. And what they showed was interesting. They looked at patients with clinical and radiographic follow-up at 2 years. It showed that radiographically they did a pretty good job of improving curves. The numbers are small, but coronal curves going from an average of 57 degrees or so to 30 degrees. So they got 60% improvement of the curves. And in terms of clinical outcomes or SRS scores improved, certainly, remember, these are adolescents, so we're not getting tremendous improvements of pain and function, but improvement of self-image and of would you like to spend your life this way. But what was interesting, perhaps most interesting, is in this series, now mind you, these were adolescents with deformity, but still had spinal deformity, multi-level fusions, and all these patients were satisfied. In fact, there were no complications out of these 44 patients. No nerve complications, no respiratory failures, no infections. These were all posterior surgeries, no reoperations. And so are we better than that? This was 2000 that he published it using, again, segmental fixation with hooks, Wisconsin wires. Are we better than that? And certainly I don't think we are. Here's a more recent paper suggesting how's there been change over time, and this is Renaud Lafage and the ISSG looking at this. What they did is they took the period of time on which they were collecting data prospectively from multiple different centers and divided into 3 equal groups over a course of 10 years. So basically a moving cohort over the course of 10 years. Followed 320 patients, and what they showed was sort of interesting. Between 2008 and 2018, that the patients actually became older, they were sicker over time. There was more pure sagittal deformity. And when I think about pure sagittal deformity, that means to me reoperations, right? Is there pure sagittal deformity, people who are fused in malalignment. There was less invasive surgeries, less 3-column osteotomies, shorter fusions, more supplemental rods. And overall, there was a decrease in complications, so a significant decrease in complications. The main thing that drove the decrease in complications was less radiographic failures, including rod failure. But importantly, there was actually an increase in neural complications. So again, if you look at these cohorts over time, older patients, more comorbidities, so sicker patients, overall, the complication rate fell, and you might expect that because the surgical invasiveness fell. But importantly, some increase in neural complications despite reducing 3-column osteotomies. And the biggest driver of less reoperation was implant failure. There was less implant failure. So in terms of what's really changed, again, to summarize this, less invasiveness, more interbody fusions, more BMP, less 3-column osteotomies, more supplemental rods. And I often talk about what's the surgical signature for cases at UCSF. And I think when we look at our cases at meetings that involve multiple different centers, the surgical signature you tend to see in our cases is a lot of interbody work, a lot of anterior work, a lot of 3-column osteotomies actually, but also a lot of supplemental rods. Now, where's there an ongoing concern? So the ISSG suggested, yes, less complications overall, but still the lowest period of complications was still 21% reoperations, and overall still 50% of people were having complications. So again, there's still some room for improvement, and this is what I think is exciting about where we're practicing now. Is this from Eric Topol's book that was published in 2011, The Creative Destruction of Medicine. And he talked about this transition from old medicine to new medicine and the notion of an inflection point where we go from basically old technology where we're looking at a case-by-case basis and looking at, well, what happened in my last case, to bringing in technology that includes 3D sensors, including information about genomics, including large data sets, social networking information, which has been really effective in some prospective studies. And this brings to an inflection point where we can really make a transition to some major improvements in what we're doing. And I think we're in that inflection point right now. We're in that inflection point where we're using large data. We're no longer looking at a single center study with 40 patients and using multivariate analysis. Now we're looking at large databases that include not only multi-center studies, but databases that include entire nations and looking at nonlinear models and machine learning type models to really create much more valid conclusions and maybe to drive better an evidence-based approach to what we do. So back in 2011, Jeff Lotz and I started a program called the Center for Disruptive Musculoskeletal Innovation. We started actually at a course like this. This was in Hawaii. It was called the Castelvi course. And Jeff managed to get National Science Foundation funding for this. And the idea was to develop new technologies that focus on value, that are disruptive, that really significantly improve what we do. And what we recognized at that time, and this is an updated slide, that we're spending close to $5 trillion a year on healthcare. It's about 20% of our GDP, and that rate of rise has increased dramatically. We're now up to $13,900 in 2003 per capita on healthcare. And that's the rate of rise that's really been unsustainable. And if we look at that trend, one way to deal with it is the SGR formula, right? So sustainable growth rate is Congress every year looks at knocking 5% off the Medicare budget. Now, doing that really isn't going to have a sustainable effect. What it's going to do is basically shift that curve to the right, but it's not really going to bend the curve. And one of the fundamental notions of the CDMI was the idea of bending the cost curve. It's to try and develop new technologies that might be a little more expensive on the front end, but then on the back end would actually save costs. And the notion would be to reduce reoperations, reduce complications, reduce the things that drive costs in spine surgery. So what are some of the drivers of that cost? Well, one is we tend to very enthusiastically adopt new technologies that add cost without actually improving outcome. And this is Paul Ginsberg from Princeton, the economist, who wrote in the New England Journal about what is it that drives healthcare in the US, is we much more enthusiastically adopt new technologies that oftentimes fail. And all sorts of examples of that in the spine world as well as the arthroplasty world. We still have a lot of complications, reoperations, readmissions that add costs that maybe we can save. And finally, I've fundamentally been a critic of our reimbursement system. I think if we really want to provide value-based medicine, we've got to pay for value rather than pay for volume. So these were some of this is actually from our original meeting, is where do we have opportunities to bend this cost curve? Well, improve the durability of our outcomes, develop outcomes instruments that might be more sensitive to change, and this is some of our wearable technologies that have been funded through the CDMI, to look at large data set analysis and to try and look where there's cost drivers. And specifically, we did studies looking at readmission, reoperation, prolonged ICU stays, identifying the outliers on the cost curve, developing diagnostic tools. We've invested in regenerative type tools with studies. We did a big study on surgical site infection, and that's been a big improvement over the last 20 years. And we did some studies on junctional pathology and avoiding junctional failures. So these were all areas that we actually identified and invested in studies to try and improve. So again, I talk a lot about the continuum of care, preoperative, intraoperative, and post-operative. And I'm going to talk a bit about where I think there have been changes that are significant in each of these phases. Now, number one, what happens preoperatively? And what are innovations that really make a difference? Well, I think some of the work we're doing now in patient-specific planning, you know, when Bobby and I first arrived, when we were fellows, the idea was you get about 40 degrees of lordosis and 60 degrees of kyphosis, and that was sort of a relative goal. But now the idea of understanding for the individual patient, how do we match alignment to what's appropriate for the individual patient? What's appropriate use criteria? So when are we likely to have a measurable benefit in care, and when are we likely to have care cause harm or not benefit? And that's the predictive models. And Chris Ames and I did a edition of the International Journal of Spine Surgery. It's got 12 articles in it that talk about some predictive models. I think our preoperative optimization pathways, basically recognizing what are the risk factors and what are modifiable risk factors so we don't bring patients to surgery in non-optimized state. And a big thing that's changed is, you know, when we first started 20 years ago, more than 20 years ago now, but when we first started, it was one PA that was shared for all of orthopedics. And now, you know, each of us work with PAs. Ashley's here, and we've got a picture of Patty coming up as well. You know, Patty was the one 25 years ago. And, but, you know, the teams that we have to look at optimizing patients preoperatively to make sure we're bringing patients to surgery well-informed. And Ann, who does a lot of this work with as our nurse navigator, and Ashley's and Arthur, a big part of my team. This is a paper we wrote early on about alignment of the spine, and what we know now has gone so far from there is now understanding that different shapes are appropriate for different spines, understanding that the common denominators, we want to get lordosis from L4 to S1, and my long-standing criticism of a lot of MIS approaches is the absence of getting lordosis from L4 to S1, and understanding that this is something that's really common. So we've learned a lot over the course of 20 years about being very precise and patient-specific in our planning. We've written about risk factors for complications and really worked on modifiable risk factors. And this is our preoperative optimization scheme, and we published this and suggesting that this might guide appropriate care for patients and being able to identify complications. Well, what about intraoperatively? And certainly I think a lot's changed in 20 years. I think UCSF has done a lot of work in pioneering interdisciplinary surgery. I really credit Vidette and Chris for starting this, for identifying the fact that there were a lot of complications in complex surgery, and working together works better. And I think all of us have really benefited that with the interdisciplinary work between ortho and neuro, between peds and ortho, and that's really been positive. Having spine-specific anesthesia teams has made a big difference, and having protocols for fluid resuscitation so we don't end up at the end of a case finding out that somebody got 5 liters of LR and no crystalloid in their hemoglobin in a recovery room is 6. Intraoperative protocols for nerve monitoring have really improved a lot. Tranexamic acid, you know, losing body volumes of blood was common when I was a fellow, and now is pretty rare. We're transfusing people non-autogeneic blood, so it's pretty rare we're giving people allogeneic blood in the operating room, even for big osteotomies. And I think a big change has certainly been navigation and intraoperative imaging and being more precise, especially with our complex cases. What about post-operatively? And I think Patty is back there, so there's your picture, Patty, is recognizing both, you know, I think neurosurgery's got 4 Patty equivalents, and ortho's side's got 1 Patty, and actually Rochelle now, but the work that's done post-operatively with perioperative care pathways. We've got this brochure that we developed on what to expect for spine surgery, explaining to patients what happens in the hospital, what happens after your discharge. And this has really made a big difference as well in terms of preparing people for discharge. We're no longer having people staying in hospital where you find out after doing a T3 to pelvis that this person lives alone in a 3-story walk-up. That kind of stuff doesn't happen anymore. And that's the sort of thing that leads to prolonged inpatient stays. Now, I think there's a lot that's improved, and I talked about it in the preoperative phases, intraoperatively as well as postoperatively, but there's still some room for improvement. You know, I still think that our reimbursement models are just perverse, and there's a real dissociation between what we get paid and the outcomes of what we do. I think a fee-for-service healthcare economy really doesn't work. There's too much incentive to do aggressive surgeries on patients who aren't likely to benefit. I think interdisciplinary panels really ought to be involved in evaluating these cases. I think there's still a lot of variability in care and some real problems with regard to access to care, and we've demonstrated that in prospective studies. I think interdisciplinary care we've really pioneered a lot of that. And again, I give Chris and Vidette credit for that. We've all worked interdisciplinarily. I think in the post-operative phase of care, having our medicine teams involved, our geriatrics teams involved, this is really important as well. Our non-operative interactions has really been important with the non-operative service that's developed mostly in the last 12 years. Predictive models, still I've got a lot of enthusiasm for them, but they need to work for validation. And I think focusing more on preventative interventions as well. And I still believe regenerative solutions, I think Rick can talk about that, but regenerative solutions may help, but so far over the past 20 years, I don't think they've done much. So if there wasn't any room for improvement, there wouldn't be any need to go on. And this is one of my favorite quotes by Robert Brown, and it is, "A man's reach should exceed his grasp, or what's heaven for?" So certainly we recognize and we continue to want to improve. And this is a great book I read recently by David Brooks. David Brooks has become a friend. He's from the Harvard Business School. And he wrote an interesting article in The Lancet about 10 years ago about when do we really reach our prime, when do we hit our peak. And in his experience, he was the oboe player in the New York Philharmonic, and he felt that in his mid-20s he had sort of gone beyond his peak, and he started a second career, and he worked in basically business and psychology. And his notion was, in the first parts of our career, in our first 20 years, he said, and this is what's relevant, in our first 20 years, we tend to be very self-centered, focusing on self, focusing on gaining in our field, gaining recognition, gaining reputation in our field. And he talked about the second mountain, and this is really committing to others. So there's a picture of the priorities that matter. And my son Ben's back there. He's a big monster. And this is he and I in the Galapagos Islands. When he kind of fit underneath the nook of my arm. And now he towers over me, and he's here with us again this year. And but these are priorities that really matter, and I think we all need to think about this as well in terms of, over the course of 20 years, this is the development of my family. One of the greatest honors I've gotten is Marin Magazine called me one of the 10 fathers of the year, and these are my boys and my wife. We do a lot together, and so in terms of the next generation of 20 years, I think defining the priorities that matter include this family and mentorship. So thank you for the opportunity to contribute again, and I look forward to time together.